Good morning, ladies and gentlemen. It's my great honor to welcome you on the Friday morning, the last day of the conference. My name is Pavel Bem. I am the member of the Global Commission on Drug Policy. I'm former mayor. I was former mayor of Prague for many, many years. And I was also the national drug coordinator at the beginning of 90s, early 90s. And I have the pleasure to welcome also very distinguished gentlemen who were or who are behind the Czech drug policy. And this session is about the story from early 90s, how the Czech drug policy, formerly Czechoslovakian drug policy, has been evolving with actually great political changes in 1989, democratization and liberalization of the society. And what is really interesting that the Czech Republic was, and Czechoslovakia was the first European country which decriminalized drug possession and drug use. And it happened in 1990. And today I'm honored to welcome a gentleman who were part of the story, Viktor Mravcik, the head or former head of the focal point of the National Monitoring Center, Jindrich Voboril, the former drug Tzar and national drug coordinator, Tomas Sadilek, who was very closely related to the logistics of the functioning of the national coordinating body, the secretariat of the National Drug Commission, and who has spent a lot of time in advocating for medical cannabis, legalization for the legal use of those who need it as patients. David Pasek is a person who is running probably the largest or one of the largest low threshold drop-in contact centers and implementing wonderful harm reduction services, innovative ones, and he together with Marek Havrda will talk about that. The one person is missing, the Czech Republic. Drug number one is not heroin or opioids, but methamphetamine, Pervitin. And my colleague from the Addictology Clinic of the Charles University, whom I talked a couple of minutes ago, is apologizing himself, but he sent a presentation, and I didn't see the presentation, but I will try to go through that because it's giving us nice angle perspective on the assisted therapy, pharmaco-assisted therapy to people who are addicted or who use methamphetamines, injecting methamphetamines dominantly. So, from decriminalization to comprehensive community-based reduction services, and I would like to invite Viktor Mravcik to introduce to us what happened in the former Czechoslovakia or the Czech Republic in early 90s. And Viktor, floor is yours.
Thank you much. Can you hear me? Yeah, okay. Anyway, next one. Oh no, I have this one. Yeah. So I would like to very briefly introduce you to the history of development of harm reduction in context of development of drug policy in Czech Republic And part of the important part of the drug policy is also the debate about criminalization, decriminalization, and the decriminalization as such, as one of the main, I would say, elements in the drug policy. As Pavel said, I'm former head of the Czech National Monitoring Center for Drugs and Drug Addiction. I resigned last month from the position, among others because I couldn't participate in the drug policy coordination which recently comes back from this direction of decriminalization and the modern and balanced and so on policy backwards to the situation maybe 10 years back or 10 years ago. So for me, this is also, I mean, special moment in this regard, speaking about this topic. Background, very, very briefly. Czech Republic is the country in the Central Europe with slightly more than 10 million inhabitants. We have relatively high prevalence of cannabis use in the general population, I would say. We have high level of drug injecting, comparing with other European countries. We are among the first in the raw, I mean, in the map or graph showing that indicator in Europe. We have high risk and injecting use of methamphetamine. We call it Pervitin in Czech Republic. So this is also kind of exceptional in European context, together with Slovakia due to the common history. Low prevalence of drug-related infectious diseases, so HIV, hepatitis. We have quite low, relatively low level of drug overdoses. As Pavel said, quite long history of drug policy, and I would say balanced and pragmatic drug policy, which started in '93, formally with adoption of the strategy, first strategy. Harm reduction is from the beginning, or very beginning, one of the basic pillars of drug policy. The drug policy is interdisciplinary from the beginning. Inter-ministerial coordination is here, including civil society. Basically, civil society was one of the main promoter of the modern drug policy, and the monitoring is part of the drug policy also from the very beginning. History of drug problem, just very briefly. Of course, it hasn't started or didn't start it in 90s. Already before, there was a drug use, drug abuse or misuse of medical drugs, pharmaceutical substances before '89 in communist times. Already in 40s, 50s, there were reports of use of amphetamine, ephedrine, morphine, codeine drugs. In 60s, there was a phenomenon of dex or phenmetrazine. So stimulants are the important or visible part of the drug problem in Czech Republic for a long time. And in 70s, 80s, methamphetamine started, which remains, I mean, till now, the major problem drug, and brown, which was homemade drug, codeine-based, produced from codeine-based pills. After '89, with opening the borders, Pavel already mentioned, there was strong wave of drug use, including mainly heroin. So we called it heroin epidemic in the middle of 90s, with aggravating situation, with moral panic around that, which was important also for the debate and the reality of criminalization, decriminalization. And I will come back to you later. Pervitin still remains the main drug in context of this high-risk drug use. With new millennium, buprenorphine entered the black market, diverted from the medical sources, from the substitution treatment. And it's the main opioid used in the context of high-risk drug use nowadays. And in the last decade, there were some reports, or I would say some signs of wave of new drugs coming to the market, for example, new cathinons, but it remained at a low level. And in recent years, we see it increase in misuse or use of opioid analgesics. We can say synthetic opioids in the context of high-risk drug use. Here you see the trend. So the red line is number of estimated high-risk drug users, so around 45,000 are estimated in Czech Republic, which is around 0.7% of adult population, which is quite above the average slightly above the average of EU countries. Majority of them, this is a blue line, are injecting the drug. And 3/4 of problem users or high-risk drug users are on methamphetamine as a principal drug. This is the 33,000, this orange column. And the 1/4, around 11,000, are opioid users. Drug overdoses, and I would say majority of opioid users are on buprenorphine, then around 1/3 on heroin, and 10% on these opioid analgesics. As regards drug overdoses, we have quite low number of overdoses annually, from 40 to 60 cases. We see a recent increase in major substances involved in drug overdoses, which are opioids and methamphetamine. Majority of drug overdoses are related to opioids or methamphetamine. In opioid deaths, we see recently increase in those opioid analgesics, including fentanyl, oxycodone, other opioid analgesics, including codeine drugs, dihydrocodeine, and so on. But quite low number. As regards drug-related infectious diseases, historically, among injecting drug users in Czech Republic, there is very low prevalence of HIV. Any sample you test, it's below 1%. As regards hepatitis C, I would say quasi-representative data show around 35% of those being, having history of infection of hepatitis C, which is also quite low prevalence. Just this picture has to show that since 2019 we have an elimination plan of hepatitis C in injecting drug users. It was adopted by the coordination body of drug policy by this National Drug Commission, 21st of August 2019, which is the day of the occupations, when occupations of the Soviet and Allies army started in 68 anyway. So 21st of August. Drug policy. Harm reduction is integral part of the Czech drug policy. It's one of the 4 main pillars, I would say historically. Just very brief look on the development of the policy in the perspective of drug strategy. The first one was adopted in '93, and the main feature, I would say, was balanced approach already in that time. In that time, Pavel was drug coordinator, if I'm not wrong. Yeah? Then the second drug policy program, adopted in '98, brought or highlighted public health as the main principle, public health in the center, and harm reduction as the main pillar. In that time, as I'm not wrong, Josef Radimecky was drug Tzar in Czech Republic. Then another one, I would say, maybe the main achievement was that focal point was formally established, and we can say that the data and information, this evidence-based, become reality in drug policy, everyday reality. Then the next one started in 2005. Maybe the main element is the introduction of quality assurance system of drug services. In that time, Kamil Kalina, maybe he is not with us today, was drug coordinator. And the next strategy, starting with 2010, broadened the scope of the strategy from previous illicit drugs to addiction as such, I would say, including tobacco, alcohol, gambling, and other behavioral addictions. And in that time, Jindrich Voboril was the drug Tzar in Czech Republic. And the last one, which is still valid, has one of the main goals: effective regulation of markets with substances and products with addictive potential, which is quite revolutionary. I mean, formulated in the strategy. Reality is the different, as I said, explaining my resignation. Well, timeline of decriminalization, very briefly, and this, I mean, debate on criminalization, decriminalization went in parallel with the development of drug policy. So as Pavel said, drug use has never been criminalized in Czech Republic. As regards drug possession for personal use, during communist times it was criminal offense. After 89, in 90, already Pavel said, any drug possession was decriminalized for 8 years. And then, in context of this heroin epidemic and moral panic around that, drug possession as a crime was introduced again. And in that time, this principle of small amount and amount higher than small was introduced to the Czech law. So below this limit, it's administrative offense. Above this limit, it's a criminal offense. In 2010, there was a new criminal code adopted, and in addition to this decriminalization of small amounts, also cultivation of small amounts of plants was introduced as a privileged offense, or how it's called. Also, punishment between cannabis or possession of cannabis and other drugs was introduced, so differentiation of the punishment. And threshold quantities were specified by government decree, or two government decrees, one for the substances as such and another one for plants. In 2013, Constitutional Court annulled this decree because it was in conflict of the constitutional principle that government can't define what is and what is not the crime, just the parliament, just the law. But the Supreme Court adopted the guidelines which are now valid for law enforcement bodies. And in that time, some threshold quantities, differentiating between administrative and criminal offense, were decreased. So kind of criminalization again in some drugs. And the last development is in 2020, Constitutional Court annulled this decree on the quantity of plants. Yeah, so we will probably have the same procedure with Supreme Court defining guidelines and so on and so on. Anyway, this is the threshold quantities. So on the right side you see the one who are valid in these guidelines of the Supreme Court, and in some, for example, in cannabis, you see that before in governmental decree it was 15 grams, which was the threshold between the administrative and criminal offense, and for unknown reasons during the debate and the adoption of this Supreme Court, it was decreased to 10 grams of herbal substance. Yes, so the rules are more strict now than it was before till 2013. So decriminalization is, I would say, long-term approach of the Czech Republic, but the waves are here coming before and back between criminalization and decriminalization. Anyway, I would like to remember Tomas Zabransky here because he was the principal investigator of the project evaluating this legal change in 99, and this project brought the evidence showing it's not efficient and recommended to the government and to the parliament differentiation between cannabis and other drugs and defining those threshold amounts. And 10 years after the project, it became reality. Pavel?
And I brought a gong to resonate with him because he is not with us today, but he is a very important person. So please, just a few seconds of silence for him.
Thank you as well. It was fully improvised, so Tomas would like it very much, I would say. He was important not only for the drug policy, evidence drug policy and the debate on decriminalization, but also for the topic we are here for harm reduction measures, substitution treatment, drug consumption rooms. He was a big promoter of that. Anyway, milestones, I'm coming to the end slowly, but I will speed up now. Milestones of harm reduction in Czech Republic. It started already in the 80s during communist times, when informal, I would say, with informal substitution of the analgesics for substitution purposes. So ethylmorphine, buprenorphine was already, I would say, prescribed off-label. In Center for Drug Abuse of Apollinaires, and they started also with the first distribution of syringes, also in that time, in 86 already. And in 92, Dr. Pressel, who was the doctor in this center in Apollinaires before, established Drop-In NGO, providing also harm reduction services in that time. And he started in 92 with experimental methadone program. There were some problems around that, and he was prosecuted for a while because he imported methadone from Switzerland illegally. But anyway, that was 1 year of pilot or experimental. Then in 93, Drop-In Center of Sananim was established. 94, first syringe program started by Sananim. 95, first outreach program of Sananim started in Prague. 97, official pilot, methadone pilot started in Apollinaires. In 2000, it was transferred into standard regime. So since 2000, we have substitution treatment in standard, as a standard treatment. Then in 2000, buprenorphine was marketed for opioid substitution treatment, which brought very important dynamic also in this high-risk drug use, because shortly after introduction, it appeared in the black market. And now it's major opioid drug in Czech Republic, with many positives in terms of overdoses, because it has this ceiling effect, but also with a lot of problems. Yeah, I'm coming to an end. Maybe. Then we also had the drug checking program, but and I will come back to that later. Since 2008, substitution was introduced in Czech prisons. In 2007, or since 2017, we have condom distribution in 2 prisons in Prague. And in 2021, so this year, we started with naloxone. Orange line shows the number of distributed syringes. So last year, nearly 9 million syringes were distributed in, this is blue column, around 110 harm reduction programs. Half of them are drop-in centers, half of them are outreach programs. Gelatin capsules as a harm reduction alternative to drug injecting for Pervitin, methamphetamine users, is a kind of Czech invention to harm reduction in Europe and globally. It's used or provided by all harm reduction programs in Czech Republic, and 250 capsules are distributed annually. Substitution treatment, in the last 9 years, there is a stagnation, I would say, of provision. As you can see, so number of clients is the same. We have problems with accessibility, availability, coverage is not ideal, affordability. Majority of Czech clients have to pay for the drug themselves. Buprenorphine, Pavel, I'm coming to an end, I know. And comparing with coverage in other countries, it's very low. We miss some, I would say, already standard in some countries, harm reduction measures. So we have naloxone since this year. We don't have drug consumption rooms. We don't have heroin-assisted programs. We have substitution. We don't have drug checking in a standard regime. Some projects here and there in some years. We have this naloxone. It's running in 7 cities, in 14 programs, altogether 600 doses. Half of them are already distributed, and there are some successful administrations, I would say. So first experience, very, very good. The reason for, there was 2 years of introduction of naloxone, and mainly the main problem was to market naloxone in Czech Republic, even if naloxone has this European registration. So administratively very difficult. Conclusions. So Czech drug policy has been historically evidence-based and balanced since beginning of 90s. Harm reduction measures are historically, or principles, strategies, are historically part of the Czech drug policy. But despite the role of evidence, policy is not necessarily driven by the evidence. And there are fore and back movements. Assumed deterrent effect of strict drug policy still has a strong voice in the debate on decriminalization and harm reduction measures. It was seen in this naloxone introduction, it's seen in the debate on the drug consumption rooms, drug checking, and so on. Low threshold services for people who inject drugs and syringe programs are widely available. Substitution treatment has limited availability, accessibility, and affordability. Naloxone distribution finally implemented this year. Other interventions like consumption rooms, drug checking are not available in Czech Republic, and there are important factors hindering implementation of this new innovative modern harm reduction measures, which are regulatory and administrative barriers, legislative barriers concerning drug possession, and negative attitudes of law enforcement bodies. Thanks, and sorry for being long, but that was kind of introduction.
Thank you very much, Viktor. No time for comments. I hope we will have, at the end of the session, a couple of minutes for discussion. Now I will invite Jindrich Voboril, the former drug Tzar. Jindrich, I would like to ask you to be as exact, perfect, short as you can be. And the theme is politics, because we've been listening to the facts and data. 30 years of fight for harm reduction and for decriminalization. Jindrich, how long did you spend at the National Drug Commission as a drug Tzar?
8 years.
8 years, okay. 8 years of political fight, please.
Well, hello, everybody. I had a dream last night, early in the morning, which was dreadful. I mean, I was talking about facts and how people don't have to die when we introduce different setup, different approach, regulated market, and people were shouting at me and saying, we don't want to listen to you. So I hope this is not the case here. But at the same time, I am aware that here I'm preaching to the converted. So I'll try to kind of follow on what Viktor said, but a little bit dreaming. Pavel asked me yesterday to dream, so I will. I'll be a little bit longer at the beginning, but I'll go faster after. This country, as Viktor said, has quite large coverage of services that we call harm reduction or low threshold. It's about 100 something services. So it's in small towns, different districts. The accessibility is quite large, and 70% of injecting drug users in this country go to those services several times a year, some often, some every day. So let's say, I think it's very much thanks to Pavel in the 90s, because when he became the national drug coordinator, the very first thing that we had was the budget for low threshold, or as we call it, harm reduction services. So I remember I was there in 1991, 1992, when I first came to the city hall. I'm from a different city. I'm not from Prague. It's the second largest city in this country, and spoke to the mayor of the city and the head of the police and said, well, we will start distributing syringes and needles to the users. And I said, well, are you mad? And then couple of years later, there is a national budget. It was a liberal conservative government. It was not the left-wing government, which shows how everything is a little bit upside down in this country. But I'm glad that this is how it is. But I'm thinking, okay, this is the situation. We can be a little bit, let's say, satisfied with what we're doing. Because one of the main reasons of developing harm reduction services in the 80s and 90s was the question, how do we get people who are out there on the streets using illegal drugs, being stigmatized, being afraid of coming, asking for help? How do we get them to services? How do we, what do we do so we attract something that we can call a hidden population or hard to reach population to the services? And I had the chance of doing my master's in Liverpool, where the first harm reduction philosophy or even a definition based on academic ground was because of the HIV problem that came the end of 80s, and early on, it was during Margaret Thatcher government. Margaret Thatcher said, okay, HIV is a bigger threat for us than drug problem. Let's welcome to our drug strategy harm reduction. And this is what I had the chance to learn it. So we introduced it to the country, and it started working. The main thing they said, well, how do we get people asking for help so we prevent HIV rather than just push them for abstinence? But let's imagine that we go further. At this moment, when we talk, who are the drug users? Yes, these are images that people have in their heads. Isn't that true? This is how most people and media portrayed drug users. So we picked any picture from internet. But what about this? Is she a drug user? Yeah, she's a drug user, no? Does she look the same? So imagine that we go further, we change legislation, we regulate market. Would maybe our possibility of helping, creating interventions be different? As Pavel said, I had the chance to experience both being a service provider for many years and then being a decision maker directly accountable to the Prime Minister, so with a lot of power for 8 years. And only then I realized how legislation actually influences what we're doing for people in services. So I think there are only two possible approaches. Maybe it sounds simplifying, and we talked the very first day about the European strategy. I was very critical. Alexis was quite positive, rightly so, of course. The European strategy is given a space to develop, but if we talk very directly, we have only two possibilities: moralistic or realistic approach. Moralistic approach is telling us society has to be free of drugs, free of smoking, free of alcohol, free of all drugs. We had this 1998 resolution of UN, drug-free world, we can do it by the end 2008. Well, we are 2021, we all know the reality. So the only realistic approach in terms of legislation, not only services, but in terms of legislation, in terms of budgets, in terms of whole approach or principle of policy, can be harm reduction, minimizing harms and risks. Because the other thing, abstinence of everybody, would mean that we are all robots. It's not possible, or it's not even healthy, I would say. Yes, I wanted to go on about it. I know I'm preaching to the converted, but I want to underline, we know what prohibition and the moralistic approach brings. Violence, organized crime, stigmatization of people, transmittable diseases, difficulty to access help, even if the people are very ill. Of course, rise of drug use, overdose epidemic, etc. The list can go on. And we know what happens in different countries, what happens with HIV, what happens with total unprecedented violence of human rights, destabilization of whole countries. This is what the prohibition brings, and it's the opposite of what we want to do and what we need to do. I think I'll skip this slide because I will go on about it. And I would like to underline, for many of us, for public, for even people working in the services, I heard it so many times, we think that legalizing or regulating market is kind of a extreme liberal approach. But the fact is that the prohibition is extreme of extremes. Can you imagine, for example, some of you smoke, I guess. Imagine that we think Uruguayan model of legal cannabis is very liberal. But imagine that if we apply that to tobacco or alcohol even, you would have to register in order to be able to buy alcohol or tobacco. Your face has to be photographed, and then you get registration, and then you go to a specialized license shop in Montevideo. It's about 700,000 people. You have about 11 shops, I think, and then you can buy only limited amount for a month. of tobacco or alcohol, imagine that. And of course, you have to be, I don't know if 18 or 21, that's fine. So imagine this situation applying to legal drugs. We would say it's a bit too harsh, no? But this, and in drugs field, we're thinking this is very liberal. So how relative the whole thing is. So, I think what is the opposite of it, the realistic approach that we call harm reduction. Yes, I think, again, I know I'm talking to the converted, but how we can introduce it to the services, and Viktor talked about it. We reduce stigma. We can set up functional services and program for drug users. We had, Viktor mentioned that we have the largest number of injecting drug users in this country are methamphetamine users. We have very low heroin use in this country. And it's very much as well connected to one particular ethnic community called Romanis. So the majority of the general population don't use heroin, they use buprenorphine. Buprenorphine is quite much safer drug. I would say it should be much more available than it is, and it should not be on the black market. But the main problem is methamphetamine. So a year ago we said let's bring Ritalin as a substitution drug for methamphetamine people and just have large substitution programs. So the answer was that the police is against it. And when the medical society asked for it, we heard, well, from the health authorities, well, the police is against it. So this is where we are always. We still are in a very mad situation when the doctors say we have a medicine to use, and the police says no. So this is still going on. I think so. This very practically introduces to Pavel is already probably going to tell me that I should finish.
No, it's fine. I have to interrupt you for a second. It's by the chance, but there is no by the chance in the universe. At the same time, now the governmental meeting on drugs is going on. I have to leave the major session to be as a member of the Governmental Drug Commission to the other room. The topic is psychedelics. And the psychedelic research showing and proving that for PTSDs and pharmacoresistant depression and for some also addiction disorders, the psychedelics are the only one or a very promising intervention, psychedelic assisted therapy. So I will leave the room now. I will ask Viktor, you just to replace me, please. And I keep fingers.
And cut me off very quickly. I'll be fast. Okay, I won't go through this. I think this speaks to itself. I won't go through this because I'm long. Now, yes. Decriminalization in this country has been since 1990. I think our history is longer than Portugal, with all respect to Portuguese model. And I also think it's a little bit more liberal. For example, that's not that I want to say we are the best, but just to put it in perspective, it's not as known as the Portugal, obviously, model. But, for example, situation with people caught with possession of drugs here in this country, you don't go to a special commission which will tell you you have to go to treatment. You just get a fine. If you have small amount just for your use, which means, for example, in cannabis is 10 grams, which is kind of large amount, but it's very little in heroin or methamphetamine, which is only 1 gram. And also we had this kind of, as Viktor said, backwards, forward, forward, backwards. We had 1998 full decriminalization of possession and no other issues around it. Then we introduced harsher measures. Then 2000, Tomas, that was mentioned and is not among us anymore, conducted this analysis that showed that very quickly after we go harsher, things go worse. Increase of level of drug use, the social cost increase, etc. So then we started again going back, trying to introduce more liberal policy, etc. And outcomes of it, I think, and that's why we should go further, is, yes, as Viktor said, lowest heroin market in the EU, low organized crime. We have virtually no organized crime. The police are creating organized crime. They put together people, say, we have organized crime, but in reality, it's very, very low. It's much more, we have bigger groups of smuggling tobacco than organized crime in drugs. Prevalence of HIV under the 1%, and hepatitis relatively low. I remember in the 90s when we worked with testing hepatitis C, the prevalence was around 60–70%. Now it's between 12 to 18%, and I believe we can go further and really go down now with the medication that we have, etc. Okay, well, Viktor is telling me to continue. So I think we are in the last two slides that I want to say. I think what rational drug policy is, the main approach in legislation, in budget, in services has to be minimizing harms and risks. It doesn't mean that we don't want people to abstain. I'm almost 100% abstinent. I really don't smoke. I don't smoke any drugs. I didn't get drunk, I don't know, for 20 years. But I do believe that abstinence is a goal for only few people. Okay, I cannot see the... Second thing that I think we have to, I think we should think about it very thoroughly in policy. What we did, and not only us, it's 11 other EU countries did the same thing. Integrated policies, something that is not talked very much among harm reductionists, but it's a strong image, I don't know, or strong change of the policy if you put all the numbers next to each other, alcohol, tobacco, gambling, and drugs which are currently illegal. And then all of a sudden the picture is very different. And then we created the possibility to put it in front of the politicians and in front of the public. And it's obvious that what we should concentrate is not going zero tolerance on drug users, but rather working around alcohol and tobacco policy, especially with the young people. We know that that people who use drugs, alcohol and tobacco on a regular basis before the age of 16, that we have all the evidence that the risk of developing addiction even on illegal drugs is about 8 times higher. So maybe the prevention and the whole effort in terms of regulations and some kind of repression is much more around alcohol and tobacco needed than other drugs, in a way. Regulated market, I think if we have regulated market, our services and what we do for people and how we can help people is much more potential, and the whole thing would look different. Maybe the services look very different because people would not have to find $2,000 a month for their monthly doses. So imagine maybe most of the people would not be homeless. Most of the people would not be involved in a crime. They would go to work, and then they would come to our services for help in a very different setup. If we have regulated market. Of course, regulated market has many other aspects, but I think in terms of services, this is very important. Because Viktor is pulling me, so I cannot go on this one. Yes. Okay, I think I'm not going to go through the last slides. You can see them downloaded, I think, on the website. Harm reduction, or minimizing harms, or whatever you want to call it, should be framing the next century of our efforts in not only helping interventions, but in the whole entire policy.
Thank you, Jindrich. And now I would like to ask Tomas Sadilek to introduce us to the topic of medical cannabis, very shortly, I guess, yeah?
Yes.
Thank you, Tomas.
Be short, and I will.
Because I was too long, probably we started late, and Jindrich is always very interesting. So
Good
Tomas,
morning,
please.
everyone. Good morning, everyone. Medical cannabis. I will take you briefly through the history of legalizing medical cannabis and bringing it into reality here in Czech Republic. But let's start in 1950s when team of Professor Kabelik, Shantavi and Krejci at the University Palacky in Olomouc, they found antibiotics, analgesic and anti-inflammatory properties of cannabis, which is funny, not funny, that 70 years later only cannabis was removed from Schedule 4 category at the UN level that describes those substances with zero therapeutic potential. So 70 years after, professors at Palacky University in Olomouc found those healing properties. At international level, it was recognized last year only. We also, I have to mention Professor Lumír Hanuš, who was, who together with Professor Meshulam is a co-founder of Anandamide and still active. After the revolution, cannabis started booming as an autotherapy plant, and from the data from 2009, 70% of people between 15 and 64 were illegally using cannabis for therapeutic purposes, at least once. And now, April 2010, it's becoming real, recognizing cannabis as medicine legally. Parliamentary seminar on medical cannabis started the whole process. It took part under the auspices of the dean of the first medical faculty, Tomáš Zima, Professor Zima, and the Minister of Interior, Ivan Langer. I believe some of you were there already. Then Prime Minister established expert-based working group, also led by Professor Zima. And important to say that within this committee, two subgroups were formed: medical and legal, reviewing the possibilities and bringing the evidence into the negotiation. It's important to say that the law it's written in accord with the UN treaties. Some people might argue, but the International Narcotic Control Board several times concluded that there is a flexibility and feasibility to legally provide medical cannabis to patients in line with the UN treaties. On February 15, 2030, bill is signed by the President, went through the House of Commons, went through the Senate, and signed by the President, came into force by March 2013. Now the harm reduction side of medical cannabis. Medical cannabis in Czech Republic, it's been now 9 years already part of the medical system, there is still lack of encouragement to physicians who treat pain and who should prescribe cannabis prior to using opioids as a harm reduction strategy. Is the fact that cannabis, unlike the opioids, there is no lethal intoxication, unlike the opioids. So cannabis has been also shown to be effective for treating nerve pain without the risk of fatal poisoning, as I said. Also, there is medical cannabis can reduce the use of other more harmful drugs. Here are some 3 studies I selected, and I also would like to remember that the whole process of making medical cannabis available to people in this country, it would not be possible without our friend and colleague Tomas Zabransky, a man who dedicated his life to treat addictions and fighting for evidence. That's it.
Thank you, Tomas, for being brave and also for remembering Tomas Zabransky again. So, please, who is next? David, please. Take a floor.
It's the end of the conference, there were a lot of parties last night, so I'm inviting you to more relaxed presentation with this picture, this artistic painting, but by Jean-Michel Basquiat, who was one of the greatest painters of the 80s of last century. This painting, Riding with Death, is one of his last paintings he did before his death in 1988. He was very young when he died. And I would like to talk about this painting as some parallel, some impression of the state of harm reduction in Czech Republic. Jean-Michel Basquiat was living in Brooklyn, New York during the 70s, and it was the time of rap music, punk music, street art, and it was beginning of the hip-hop music culture, and it was really crazy times. He used social commentary in his paintings as a tool for introspection and for identifying with his experiences in the black community of his time, as well as attacks on power structures and systems of racism. His visual poetics were actually political and direct in their criticism of colonialism and support for the class struggle. When he was 13, his mother was committed to a mental institution, which led to much of the instability and unrest in his childhood. At 15, he ran from home. His father kicked him out of the house for dropping out of high school, from which point Basquiat lived homeless for many years. And after a young career of art, he died at the age of 27 due to heroin overdose. I was thinking, because I really like his art, if he could profit of opioid substitution treatment in his time. We really don't know that, but the availability of this approach maybe would answer us. But still there was no availability in those times, and there is no availability for opioid substitution treatment for more than 5,000 human beings in Czech Republic at the moment. I find that fact very disturbing. About the picture, some details. There's against this flat brown background, Basquiat has painted a dark-skinned male figure who sits on top of a skeleton on all fours. This brown color is one of the possible color shades of heroin, sometimes background for relief and happiness, as riding a horse through the nature, but other times also for suffering while riding on skeleton through infinite muddy fields. Victor was already mentioning the numbers. In 2019, there were approximately 45,000 people among the most vulnerable community of people who use drugs. Almost 11,000 are opioid users. And also in 2019, there were 61 healthcare providers registered opioid substitution treatment, and they were offering in registration only 2,500 persons treated in OST. However, there is an estimation there is 5,000 people in total in OST treatment. Now, what's the relation between the horseman and its skeleton horse? I don't see harmony and union that we can see between passionate riders and their beloved horses. There is tension and stress about the uncertainty, what will happen next. Will the horseman trembled off by insecure skeleton horse? Will be the horseman cruel while using spurs? Who will fall? And what about those 5,000 that are in OST in Czech Republic? The usual dosage is 8 milligram. Is it enough, or are we under-medicating these people? Do the strict rules about positive tests to other substances and stopping the OST for some time helps? Are we human-centered or just follow the rules of the institution? Drug services in Czech Republic emerged mainly thanks to professionals, and we have done an incredible work. Thanks to this, we are many times showed as a good practice example of rational drug policy and functioning net of harm reduction services. There was never strong movement from the bottom, and it's probably something that we are missing through all the processes of evolution of drug policy and drug services in Czech Republic in the last 30 years. Maybe there are some patient organizations, but there are not many patients there, and definitely they are not people using drugs. So the community does not have strong voice at the moment, and if this conference helps to support the rise of such network as is Euro input, then I think the mission of the conference is accomplished. Basquiat came from a troubled family, although it is not documented that he had a specific mental illness. through his work, you could tell he may have been depressed or traumatized by his childhood. Growing for him was definitely not easy. He made money by begging on the streets and selling t-shirts he made with his art on them. Then he began to use drugs, and as I already said, he died from overdose from OD on heroin at the age of 27. Young artists are still portraying their inner difficulties in their work instead of talking about it. Society has put the crazy label on those with mental illness. They bash people way more than they try to understand them. That's why I believe most people who need help are afraid to get it, because society has never made mental illness as an okay thing or doesn't support it. Eyes of the white skeleton are crossed out if you look in detail at the picture. Basquiat's roots were Afro-American, brown-skinned figure is mutilated only with one leg and actually decomposing. The skeleton's look is strict and rigid, crossing out what is not normal, what is different. Judgmental eyes are certain about who is okay and who is not okay. There were parliament elections a few weeks ago in Czech Republic. It's still said that it's always time when the elections come and there are campaigns that the most vulnerable people are still pointed out as the roots of the main problems in the society. Sadly, this attitude wins political points. Our drop-in center Sananim is located on Prague 5, location with a long-term drug market situation. As there are no DCRs, the most vulnerable and homeless do use on the streets substances. Before the elections, my mayors of Prague 1, 2, and 5 came with a declaration demanding to create and have access to a database of clients of drug services, and that people with provable faulty and poor behavior at public places should be banned outside from the city of Prague. Those are all, this is all against human rights. This is how election campaign can be made in 21st century in Czech Republic. The political party is right conservative and is among the coalition that won the elections. Basquiat suffered from mental illness in his family anamnesis. He also suffered from homelessness and being on the bottom of the society. He was using drugs, as many people use drugs, to feel relief from some pain. The human on the picture is clearly suffering, decomposing alive, losing limbs and mental health. Or people are suffering the same way of traumatic events in their lives, attachment disorders, dual diagnosis, severe somatic complications, social exclusion, homelessness, and so on. Many people think that Riding on Death is Basquiat's last picture, but it's not. The very last picture is called Dry Cell. There is a monkey in a circle. Basquiat, with Haitian, Puerto Rican origins, was victim of systematic racism and was many times called monkey. He died very young at his 27 years, and it's pure sadness, ending life and feeling this struggle to be accepted to the world and to oneself. Harm reduction is about support and respect. We try to deliver interventions of reductions of harms to as many people as possible. On the other hand, we see everyone and each person as every person matters. That means that we are also offering compassion and healthy relationships to help the most vulnerable to arise from the void to better places. Let's focus on the reversion of the right on the skeleton, not toward death, but toward life. So many people in the community are suffering and need the support, not only from their networks, not only from drug services and professionals, but also from policymakers and decision makers. I am so happy to be here among people with similar objectives. And let's use the knowledge from the conference to advocate toward more rational drug policy with broader support of not only opioid substitution treatment, but also stimulants substitution treatment, opening of DCRs, support of medical cannabis, drug checking, broader decriminalization and regulation of markets. And last impression, if you look at the skeleton, it's losing its contours and fading to the brown field, and the human body is transcending to inner peace. The void stops to be unsettling but warm and calm. We are in Czech Republic sometimes focused too much on abstinence, but it's not important if the person is using or not using substances, but if it's living in satisfying, healthy relationships with other people. This conference has many topics, and also social inclusion and inclusion itself. And what is inclusion more than our openness to go to sincere relationships with the most vulnerable. Thank you for your attention.
Thank you, David, for this unusual presentation with 3 slides, basically. Very important issues. Please, Marek, if I can ask you. And I ask you to dedicate 10, maybe a few more minutes to Marek. We started later, so we can, close the session a bit later, I guess. So, thank you much.
Hello, my name is Marek Havrda. I'm a last year student at the first faculty of medicine of the Charles University here in Prague. I'm as well a leader of a student organization, Medici na ulici, which means medics or medical students in the street. And I'm a medical worker in the contact center Sananim. In the few minutes that I was given, I would like to present our student body organization. I would like to explain why we exist, what is our role, what role do we play in the context of low threshold services, and point out some of the biggest challenges that we face today and show you how are we trying to approach them. So, who are we as Medici na ulici, and why do we exist? We are a student-run organization that provides stable and frequent medical care to homeless people in Czech Republic. In 2 university cities, Prague and Brno. About 9 years ago, there was a medical student that started assisting a nurse in a Salvation Army center. She found the work very interesting and mainly meaningful because there was just so many people to take care of that couldn't get the care elsewhere. Along the way, she picked up some other friends from school and formed the first version of the organization that we are today. Short after that, I started medical school, and thanks to my dear colleague and friend Ruth, that is sitting over there, I joined the movement as well. Our project is based on the fact that we feel like it's simply not okay that in the 21st century there are tens of thousands of homeless people in Czech Republic, and many of them in a medical condition similar to the time before the even first antibiotics were invented. We were concerned with the severe lack of basic primary and medical lack of basic primary and follow-up medical care, so we decided to organize ourselves a bit and contribute to the community of low threshold services and from a medical point of view. So how far did we get since then? After 5 or 6 years of more organized activity, we have 5 medical stations in Prague. We managed to enrich the university curriculum with an elective course of street medicine. We actively participated on multiple domestic and foreign conferences. 60 of our colleagues and friends of our students experienced a senior position in our project, which means leading the medical station. Hundreds of students experienced a junior position, which means short-term experience with our work and understanding of basic principles of our work. A point that we are particularly proud of is that with the help of our friends from the Masaryk's University in Brno, we managed to open a second branch of our organization and expand the care for a lot of people in Czech Republic. And last but not least, 9 of my friends and senior members of our organization started working as a part-time employee in one of the Prague's low-threshold services. So after all these, or couple of years, what do we see from our point of view as the biggest challenges? The first is a serious lack, as I said, the serious lack of basic primary and follow-up medical care, which is a setting with a negative impact on our clients as well as on the system. For example, without the follow-up care, our clients often get medically decompensated very fast, and they use the emergency medical care, which costs a lot. So, where is the problem, or a part of the problem? Besides the fact that there is a lack of physicians and nurses, the public medical system expects the patients to fully recover at home, so the hospitalization is shortened to the bare minimum. This of course, disqualifies our clients because they just don't have a home to recover at. Well, how can we try to solve this issue, or at least contribute to solving this issue? Expand your multidisciplinary team with a medical worker. This person is familiar with the public health service, can play a role of a mediator, can evaluate health risks of the client, and with good communication skills can in general lower the threshold of reaching the public care in a regular way. The main aspect of my presentation and an important take-home message is that this position doesn't have to be assigned to a physician. If you don't have him or her, or a nurse, it can be assigned to a medical student. In our contact center, there are 2 medical students and 1 physician right after graduation, Ruth, as I said already, and we provide a number of medical services. We provide care of acute and chronic wounds, mainly skin infections and complications of injections, etc. We We test for infectious diseases such as HIV, Hep C, Hep B, syphilis, tuberculosis, and COVID-19, and we have the privilege to use the PCR machine, so we don't only screen for those diseases, but we can also use a diagnostic method to test them. We offer a basic evaluation of health and a possibility of written evaluation with the stamp of our service and a signature which helps the client to communicate in the hospital setting. Also, the knowledge of having something physical in their hand, written with actual medical terminology, gives them a bit more courage to walk into uncomfortable environment. We can set up a plan of giving out long-term medication that the client brings from elsewhere, and of course we can assist the client to a medical facility. The second problem is insufficient awareness of specific and objective barriers of homeless people and people who use drugs, and various ways of approaching them. An effective way to work with this issue is to include this topic in a university curriculum, an elective course as we have, for example, and motivate as many students as possible to come, see and experience the service. I believe that even short-term experience of our work and understanding of basic principles has a significant impact on lowering stigmatization of our clients in the hospital setting. The third and last is, from our point of view, is systematic underestimation of mental health care among medical professionals and lack of active improvement of soft skills. I would like to approach this topic from a more personal level. When I started to work for Sananim, I was truly shocked with the extent of time and energy invested in mental health of the team and individual staff. This experience touched me deeply, and because of that, as a leader of our organization, I try to motivate our members in senior positions to join our team in Sananim or other organizations. I believe that if there is going to be, or I don't know if I believe, I hope that if there is going to be enough of us, maybe we will make this a standard in the hospital as well. Thank you for your attention.
Thank you, Marek. I will pass on to Pavel. Pavel didn't know that we made an agreement that we will prolong the session for a few minutes. So he's nervous, but we are calm.
Yeah, because we ran out of time and you deserve break and coffee. So I skip the last presentation of Jakub Minarik, the HR challenges for Pervitin and other stimulant users, with just one sentence. For approximately 15 or maybe 18 years, we are experimenting, providing Pervitin users with Ritalin, Strattera, and other central stimulants. We have quite promising experiences with that in stabilizing the use or lowering the use, stabilizing the social status and the health status. And I think it's a song for future. If there is anybody who would like to share our experiences, we can just do it within the corridors of our hotel. And now, if you don't mind, I would leave the last, let's say, 3 or 4 minutes for questions, if there are any, please. Yes. Můžeš to oběhnout?
Thank you. Thank you so much for this amazing country. My friends asked me to ask you about the overdose program, naloxone program. Why this program was started in the last year, 2011, 12? 21, this year. And where we can, what's the pharmacy situation with naloxone, how people can get to naloxone, and why it's only this year the naloxone program exists. Thank you.
Very shortly, it was initiated 2 years ago. It took us too long time because mainly the main problem was to import, to market naloxone on the Czech market, despite it has the European registration. Simply this administrative procedure was so complicated and complex that's the reason. We use the Nixoid, 300 packages means 600 doses, 7 programs 14 programs in 7 cities. Half of them are already distributed to users. First applications are already here, like 20 applications, successful, averted overdoses. Yeah, so quite good experience, but I pointed out in my presentation, really it also shows those bureaucratic, administrative, legislative barriers towards implementation of the, I would say, essential measures to prevent overdose. Yeah?
Jindrich also want to comment.
Yeah, just a short comment, because it has never been a priority in this country, because it's the main drug of choice is methamphetamine. The overdose rate is very low. We have about 30 to 50 people in the whole country a year overdosing on heroin, and all drugs together. I think half of it is solvents. So it's never been a big thing here.
From
so
the public health perspective.
But we never needed it as much, so it was never such a focus on it.
Yes. Some other question from the audience? Yes, please.
Thank you very much for all presentation. It was really nice to see what Czech Republic doing in the drug policy level, but also in the field of the services. My name is Vlad Kutekov. I'm coming from Macedonia, from organization HOPS. And I would like to ask, because in my country, after heroin epidemic, now we have cocaine epidemic. And we don't have any kind of the treatments, but also harm reduction activities. Is there any program which is most relevant for cocaine user in the Czech Republic? Thank you.
Can you start?
Pavel. Well, we don't have that much high-risk cocaine users or even crack users in Czech Republic. I don't remember if any crack user was reported to the system. So cocaine is not the problem in the Czech Republic. We have this methamphetamine problem, this Pervitin, which is quite similar. It's also central stimulant, and the situation here is similar to the portfolio of modalities available for cocaine users. As Pavel said, we have some experience with off-label substitution with central stimulants. There are few medical doctors providing it, like single cases a year, I would say, but quite a long history. And even last year, Society for Addiction Medicine, I would say in the context of COVID, issued a recommendation for pharmacologically assisted treatment of methamphetamine users with the central stimulant. So we have even guidelines for that now. So hopefully it will be growing, except that, I'm speaking about specific interventions, we have these gelatin capsules for methamphetamine injecting users, which is very specific, I would say, Czech specialty, also in European context, but it works for some users, mainly integrated users, who simply don't or can't inject either for the purposes they are, for example, in work or something like that. So it's not like, they can't inject due to circumstances or due to setting they are, or they have damaged veins, for example. Yeah? So it's working for some.
Short comment from Jindrich.
Well, I think it's missing here. It's a different, let's say, I don't want to use the word class group, but financially group that has usually a higher income. But yes, what is very important, I think, that services that are geared to opioid users usually are quite different. I had a chance to work for several years in London, which was geared to heroin users, and a few crack users came and few amphetamine users came, but it was very much geared to heroin users. And I think it is important to think that if I want to work with stimulant users, dynamic of the interventions are different, and I think it's very much not only what we practically do, that's one thing, but because I also had the chance to work in Latin America where cocaine-based drugs are the main thing, but it's also how the staff is equipped with knowledge and skills to interact with people who are on heavy stimulant use, because the troubles are very different, because the effects are very different. And this is very much in this country that we work with amphetamine users. So the people come into our door in the drop-in centers and in low-threshold programs. The behavior is very different. For example, the resemble paranoia of many of them, etc., etc.
Thank you very much. So thanks for your patience. I hope you enjoyed the major session, and I would like to conclude with 3 short statements. First, Czech Republic was the first to decriminalize in Europe. Okay, it's good. Still, we are fighting for keeping at least a partial decriminalization ongoing. It's a never-ending story. Second, you are a good country in designing and implementing cheap and available harm reduction services or health and social services for those who need them, for those using psychoactive substances. And the system is here and has a good sustainable financing. So we are happy for that, but still we have to keep going, because all the time we are confronted with the reality, and COVID is another confrontation with the reality of financial constraints and budget cuts. And third, still even in a country like the Czech Republic, events like Robert Veverka once may occur even in the year 2021. Gentlemen, for 11 years, providing the public once in 2 months with information, facts and data in a journal which is called, okay, but yes, why not? Legalization. Okay. Perfect source of information. Okay, Robert Veverka was just 1 month ago, 2 months ago, accused by the state prosecutor and police for what?
Inciting and spreading of toxicomania.
So inciting and spreading of toxicomania, this was a paragraph of penal code. I am aware of that. I was accused also, and other people were accused, not for distributing, for example, methadone in this country in 92, as you have heard already by Dr. Pressel, or distributing sterile syringes and needles in 93 in the Czech Republic.
Me too.
So even in the year 2021 in the Czech Republic, this may happen. So this is a case. So I pray for you, Robert, and I pray for the freedom of speech, and I pray for the respect to human rights, and I pray for the respect in general to humanity. And thank you for being with us.